So, what is a plan of care? What is our treatment for this patient, right? So, initially, our big plan is to restore range of motion. He's a little bit limited still with extension and flexion. Both of those things are going to be a priority. Extension a little bit more important than flexion. So, what do I do as a clinician to restore range of motion? Well, I like to do soft tissue work. So if you're limited with knee flexion, I like to work on the quad a little bit. If we're limited extension, we're going to work a little bit on the gastroc, a little bit more on the hamstring. Okay. We can also do some patellar mobs. I'll also sometimes do some tibiofemoral joint glides to improve that range of motion. And then just doing passive range. Okay. So bending that knee, extending that knee, helping them to get that range of motion back. And then we give them a pretty thorough home program of range of motion to be done frequently over the course of the day. So I like to use frequency over intensity, meaning that I'd rather have the patient do easy range of motion multiple times throughout the course of the day for a lot of repetitions over really jamming that knee into flexion or extension. Now, if someone's not progressing over the course of time, we start incorporating things like low load, long duration stretching, more intensity, that type of thing. But if the patient doesn't need it, I don't push it, right? Next big priority is going to be normalizing the quad contraction, okay? And limiting that quad lag during straight leg raise. And early on in our program, we actually like to use NMES, neuromuscular electrical stim. So we put stim pads on the quads. We stim the quad while we exercise to try to get that quad contraction back, as well as just adding frequent exercise. So I'll tell my patients to do quad sets, knee extensions, 3 up to 5 times per day, 15 to 25 repetitions to just get that quad back on board, right? Next step, we're going to minimize swelling. So minimizing swelling in my mind is going to be managing exercise appropriately, managing the amount of standing that you do throughout the course of the day, and also managing walking, right? Because we want to exercise, we want to get back to standing and walking. We know that all of those things will actually pump some of the swelling out of that area. But if we do too much of that, it's going to increase swelling. So we just have to be smart about how much we do and slowly progress over the course of time, with the idea that when we advance or exercise, we're probably going to increase a little bit of swelling, which is not the end of the world. But we need to make sure we don't swell too much because that can set us back, right? And lastly, we just need to restore that strength as much as possible. We want to restore that loss of hypertrophy. Now, this research is in people that have had meniscus surgery, right? But if you have a meniscus surgery and you don't restore that strength, right, that lack of strength is something that predicts future osteoarthritis. So in my mind, I want to get that strength back as much as possible, right? People always ask me, where do you start with rehab, right? So generally speaking, I want to pick tolerable exercises. So I'm picking exercises that the patient feels are tolerated well. And I want to give them as much as they're capable of, right? This is not a post-op patient. I am not so concerned about re-tearing that meniscus, although obviously I don't want to cause more damage. But what that means is I can give them a lot of exercise and I can give them as much as they're able to tolerate without causing more tissue damage, probably, right? So really, when you see these patients for the first time, you're attempting as best as you can is to meet them where they are in terms of rehabilitation. And oftentimes there's a bit of trial and error that goes on here. So during that initial evaluation, I'll try some squatting, I'll try some lunging, step ups, I'll try a variety of exercises, right? We'll give them the hardest exercises that they can tolerate really well. And I'll just set that expectation that we may mess up. This might be too much. We'll see how you feel tonight and tomorrow. And if you're super swollen, if you've lost range of motion, right, and you're super painful, we did too much. We got to back off. And they do extremely well and they feel like they could handle more, we just do a little bit more, right? And we just progress a challenge over the course of time. So as we progress, and we're going to go into the specifics of this, we also want a gradual return back to the activities that the patient can't do right now that they want to be able to do. So what's that? Running, strength training, hockey, and work activities. So we have to break down the work responsibilities, what someone has to be able to do at work that they can't do, and come up with a plan about how we do it over the course of time. And we do it in a manner where we do easy stuff and we progress to hard stuff, right? Simple and easy, okay? In terms of physical therapy, I am a less is more type of guy, right? I am an out-of-network provider, meaning that it's a little tougher to get insurance reimbursement working with me. It can be a little bit more expensive for the patient. I tend to work with very motivated patients. So I tend to see patients a little less frequently with the expectation they're going to do a lot of work on their own, right? So for this patient, we started with once a week. For some folks, it's more or less. I tell folks, it depends on how much you want. It depends on your progress. If you're not doing well, we may need to add a little bit more. If you're doing extremely well, we can do a little bit less, right? So that's just a decision I make with the patient, depending on the type of injury they have and also what they want from a physical therapy perspective. And then we can always change that over the course of time, right? And lastly, for our plan of care, we need to modify painful activities for the moment, right? With the idea that if we do too much of basic lifestyle things like squatting, kneeling, walking, it may delay our progress over the course of time. It may make things a bit more painful for the patient. We want them to have a good experience. So initially, we had to decrease the amount of prolonged standing and sitting that we did, just basically breaking things up throughout the course of the day before things got too painful. We had to reduce the amount of prolonged walking as well. I'm a big fan of using a pedometer with my patients just so they have an idea of how many steps are taken throughout the course of the day. And we can break up some of the standing and walking throughout the course of the day and decrease the amount of steps as needed, right? Lastly, the big thing I like to tell my patients is just be nice to the knee, right? Don't do a bunch of things that make it feel really bad, okay? And over the course of time, we just slowly ramp back into the things that used to hurt. So in terms of loading the lower body, that's how we get out of pain, right? So if you look at the research on knee pain in general, but particularly for the meniscus, loading is helpful for these folks, right? So that's going to be our primary way of getting our folks back to pain or back to activity and out of pain over the course of time. And I wrote his entire lower body program, right? And from a strength perspective, 3 times per week, we were doing compound movements, right? I'll tell you what those are in a minute. 2 times per week, we're doing some sort of isolation work with most focus on the quad because that's what was weakest. And the 1 time per week, we're doing blood flow restriction training. It's funny. If you follow me on social media, it kind of looks like all I do is blood flow restriction training. And the reason for that is just because BFR is one of those things that most folks don't have access to at home. And I want to make sure that I maximize what we do in the clinic by doing activities that the patient can't do on their own. So anything the patient can and will do on their own, we have them do on their own, and things they can't do without me, we do in the clinic, which is BFR generally. So what type of strength training do we do? So from a bilateral perspective, we're focusing on the squat and the deadlift. And initially, we're using a force plate as well as mirror biofeedback and video biofeedback just to promote symmetry between left and right. Okay. Like I said before, this patient was shifting weight over to their non-painful side. We want to try and normalize that. We also focused on single leg strength. Single leg strength is phenomenal because we're working on restoring any asymmetry that we found in the evaluation. And I like split squats, single-legged squats, step-ups, and single-legged deadlifts. I put a little more emphasis on quad dominant single-leg strengthening simply because that's what was most limited and was limited in the future when we continue to do more strength testing over the course of time. And lastly, a lot of isolation work. I used to poo-poo the idea of isolation work. I thought it was silly and stupid. The only problem is that if all you're doing is functional stuff like lunges and squats, it's pretty easy to compensate over the course of time. We have specific weaknesses. So what's better than isolating those specific weaknesses? So we focus mostly on the quad, but there's also isolation work, as you'll see, for the hamstrings, calves, hip, and core. So what did the home exercise program look like? And it's funny, I'm calling this a home exercise program because that's what we call it in the world of physical therapy, but really it's just a gym program, right? So I wrote a 3-day per week program for my patient to be doing at the gym, okay? So there's a day 1, there's a day 2, and there's a day 3. I ask my patients to have a day's rest in between these sessions. So day 1 would be like a Monday, day 2 is like a Wednesday, day 3 is like a Friday, okay? On day 1, we start off with goblet squats to a ball. We did 3 sets of 8 to 10 repetitions. Initially, we're keeping reps a little bit higher just because he's not tolerating much load. The range was also partial. We went to a ball as opposed to going all the way down. We also utilize dumbbell split squats. We used a long stride length, which reduced a little bit of stress on that knee. And we went through a partial range to an Eric's pad. After that, side bridge abduction. So we're hammering those hips hard. Next exercise was a heel tap with a band behind the knee. We did not use an elevation. It was a very short range of motion just because he's not tolerating a lot of end range flexion quite yet. But we got to start hitting that quad, and some core work afterwards with the band resisted dead bug, right? So like I said, this is all based on trial and error. So the first day in the initial evaluation, we just tried a bunch of movements, and then I did my best guess of trying to figure out where that patient was, okay, in terms of what they tolerate. Day 2 was a single-legged leg press. Number 2 exercise, a low box step up, followed by a standing deficit single leg calf raise. Lastly, a machine single leg knee extension to hammer that quad, and then a plank with an overhead reach, a little bit of core at the end there. Day 3, we focus on a kettlebell deadlift. We started with the kettlebell just because the knee wasn't tolerating a lot of load and he was compensating quite a bit. Kettlebell tends to be a little bit elevated in terms of depth as opposed to a straight bar all the way down to the floor, right? We also had some single-legged deadlifts, some side bridges, and some lying hamstring curls with some machine double leg knee extension cherry on the top, okay? And that made up the initial home exercise program, gym program. Now, what is a traditional treatment session at Champion Physical Therapy with Dan Pope for a meniscus tear, right? So I want to give you guys an idea of what we actually do in the clinic, as well as what the home program looks like for these folks, right? So when the person comes in initially, I'm going to ask a bunch of questions about how the knee's feeling today, because that's going to potentially do a few things. So A, change what we do that day in the moment, right? But B, it's going to give us an idea of whether or not we're moving in the right direction. And if we're not, we're going to have to change some things, right? So after we go through that, the next thing I do is just check that range of motion at the knee. So range of motion is going to be one of those things that tells us how we're doing, right? Is there a ton of swelling? Are we getting less range of motion? That's going to be an indication that maybe we're pushing too hard, right? If the range of motion is the same, great. If it's better, awesome. We're moving in the right direction. And the second thing I do is I treat that range of motion deficit. So I take a look at which direction is most limited, and I start working on those ranges. And for me, that's going to be some sort of soft tissue mobilization. So if someone's limited with knee flexion, I'm working on the quad. If they're limited with knee extension, I'm working on the hamstrings and the gastroc, right? I may follow that up with some patellar mobilizations and some tibiofemoral joint glides as well, and some passive range of motion, right? After that, I like to follow it up with some active exercise. So for gaining more knee extension, I might do some terminal knee extensions or some straight leg raises. If someone's limited with flexion, I have them do some self-flexion exercises, all right? After we finish up with the range of motion, we're still dealing with that quad lag as well as the quad contraction deficit. So I love using STIM and MES on that quad to try to gain that back. Early on, we'll do NMES with BFR at the same time, and we'll choose basic and easy exercises that are tolerated well to isolate the areas that are limited. So I'm doing quad sets, I'm doing knee extensions, I'm doing straight leg raises, internal knee extensions with the BFR, with the NMES. Let's get that quad rolling, right? After we do that NMES, we get the quad going. Then we focus on squats, deadlifts, and lunges. And I like to use our force plate, the Vald force plate, as well as mirror and video biofeedback, just to try to normalize the patient squat, deadlift, and lunge. So how do we progress our treatment over the course of time? Well, basically, we're trying to load the area more and more and go from easier exercises to harder exercises, right? So fairly simple. I start to progress split squats, single-legged squats, step-ups, and single-leg deadlifts more over the course of time. We test the patient. So we test the quads, the hamstrings, and the hips. We see if there's any asymmetries between sides, which over the course of time, everything cleared up besides the quads. So that became our focus. We want to make sure that we get that symmetry back over the course of time. So how do we progress these exercises? Well, we progress the depth. So from a squat and a lunge perspective, we go from an elevated squat, elevated lunge, and we go to a deficit or just a full range of motion over the course of time. Another easy way to increase the challenge of the movement is to add more load. So maybe I'm starting off with a contralateral load. So basically a kettlebell on one side while I'm doing a split squat. I progress towards holding 2 dumbbells, and eventually I progress towards having a barbell on my back. We can add more anterior knee translation. So if I'm going down in a squat and I don't feel good bringing my knees forward because my knees are painful, then maybe I start with more of a box squat, but over the course of time, I actually want those knees coming forward. So I'll progress towards maybe more of a front squat, and eventually maybe I'll add a slant board or heel lift to really drive that knee forward and increase stress on the knee and the quad, right? And the last thing that's easy to change is just your speed. So if you do a split squat nice and slow on the way up and down, generally it feels pretty good. It's not a ton of stress with the knee joint. And as I start feeling better, I just increase that speed a little bit, right? Now, guys, this is not meant, at least this lecture series today is not meant to be a lecture series on exercise prescription for knee pain. However, if you want to learn more, I go super in depth. I have an entire lecture series. I think it's 4 or 5 videos that are 20 to 30 minutes in length. So very, very in depth on exercise prescription for folks who have knee pain. It's inside of my Fitness Pain Free Insiders program, right? So I'll put a link in the bio if you want to check that out. And it's called How to Dose and Progress Exercises for the Knee. And in that, we have a specific area for the meniscus. So we'll teach you how to do exercise prescription dosage from A to Z there. If you want to check it out, link in the show notes. So how did the plan of care or the gym program progress over the course of time? Okay. So for the squat, we started with a goblet squat. We went through a partial range of motion, and we started with higher repetitions. And over the course of time, we did full range of motion, and we progressed to a barbell variation, so a back squat. We took the repetitions down, right? His split squat with a long stride turned into a regular squat stride, and we did a forward lunge, right, which is a bit more stress on the quad because you have to control the forces of taking a step forward and striking the ground eccentrically with the quadriceps. And it's a little bit more stress on the quad as a result, right? We increased the anterior knee translation on the heel tap, and we also added an elevation. So he was basically doing his heel taps with a slant board, right, with a little bit of elevation underneath the slant board, so a little extra range of motion to increase the challenge on the quad over the course of time. With the single-legged leg press, we just lowered the repetitions and increased the sets over the course of time. With the box step up, we just had a higher box, which is an easy way to progress over the course of time. The kettlebell deadlift turned into a trap bar deadlift, and we lowered the reps over the course of time. And then for the exercise where we're isolating muscles, we just got stronger. So that was an easy way to progress things. So how did the treatment progress over the course of time in the clinic? Well, things are pretty much the same. Patient comes in, I ask them how things are progressing. Generally speaking, as we progress further into the rehab, things become a bit more routine. We start to be a little smarter about our treatments. We tend not to have as many setbacks, and we don't have to change things quite as much, which is actually pretty nice. It makes things easier for the clinician over the course of time, right? I'm still checking range of motion, and I'm treating what I find. So he gained his extension range of motion back pretty quickly. Phenomenal, right? I don't have to focus on that. So we just focused on regaining what we didn't have, which was knee flexion. And then we just progressed the challenge of the knee flexion exercise over the course of time. The other thing that my patient had to be able to handle was kneeling. So we combined knee flexion with kneeling, which I think was a nice functional way to improve his flexion over the course of time. We started off with quadruped sit backs to improve knee flexion. We progressed to a tall knee flexion. So basically kneeling up nice and tall, then sitting your butt to your heels over the course of time. We progressed that to a half knee flexion. So going to a half kneel and sitting your butt to your heel, which is just more pressure into knee flexion. But it's also pretty functional because if you have to lay tile all day long, you're going to be doing a lot of kneeling. The knee has to be able to tolerate that, right? So after we work on that range of motion, we actually started to progress towards more plyometric activity, which as he was progressing on his knee strength, the symmetry was coming back, we start to incorporate some of this, right? So we do a dynamic warm-up after we've done the range of motion, consisting of pogo jumps, sleds, jumps, and running. We finish that up with some squatting, deadlifting, lunging, again with the force plate and mirror biofeedback. And the last thing we do in the session is generally some sort of blood flow restriction. So you'll notice the order changed a little bit. One of the things about blood flow restriction training is that it absolutely destroys your legs, right? So if you start with BFR, you're probably not going to have good quality of movement afterwards, right? So it tends to be more of a finisher when the individual progresses further along into the rehab program. So, how do we progress back to plyometrics once the patient can tolerate it, right? So, I generally start my plyometric progression with some pogo jumps. So, we do pogo jumps. If you don't know what a pogo jump is, imagine standing with your feet together and just jumping up and down nice and easy, right? That's a pogo jump. Over the course of time, we introduce multiple planes, right? So back and forth, front and back with a split stance, feet wide out. So going out wide and coming back together. I also like to do nice slow jogging early on. We do some tall shuffling, some tall karaoke, right? And this is my basic introduction to plyometrics. I usually do this for about 2 weeks. And if the patient is tolerating that really well, we start a return to run program. So I stole this directly from Chris Johnson. I've been using it for years. It works really well. Patients do a 10 to 15 minute run, right? And generally speaking, you're doing this 1 to 2 times a week. Some patients will do it 2 to 3 times a week if they really want to get back to running. That's their major goal. But it's not 15 minutes of running straight, right? So week 1, we start with a 30-minute jog, nice slow jog, and a 30-minute walk. And you repeat this interval until you're done your 10 to 15 minutes. Week 2, you advance the jogging and decrease the walking. So it's now a 40-second jog and then a 20-second walk. Repeat 10, 15 minutes. Week 3, 50-second jog, 10-second walk. Repeat 15 minutes. And week 4, there's 3 by a 5-minute jog and with a 1-minute walk in between. And that's about 15 total minutes of jogging. That's going really well. Then you can just do 15 minutes of jogging. And over the course of time, you can either increase the amount of volume, so 15, 20, 25 minutes of jogging, or you can start to increase the intensity, which usually for me is some sort of interval running program, right? So generally about 2 weeks into this return to run program, if the patient is doing really well, we start to incorporate more change of direction work. And usually the very start of change of direction work for me is going to be a little bit of sled work, where we work in multiple directions, right? So lateral sled drag, lateral shuffle. I also like ladder drills. So one thing about ladder drills is that they are a phenomenal, basic, and easy way to start incorporating some change of direction work. I think you have to be careful though, and this is what I see at a lot of physical therapy clinics, is that ladder drills in their mind are advanced change of direction work. It's not. It's generally relatively easy. Those forces are not huge. So I think it's a good introduction, but you probably have to work towards more challenging change of direction over the course of time, right? Once the patient was tolerating these basic change of direction moves with the sled as well as the ladder, we start progressing towards shuttle work. So I'm doing shuffling, lateral running, backpedaling. We start with shorter distances and we work our way to longer distances. Over the course of time, we didn't have to do this much with my patient, but just to give you an idea, if your individual is getting back to, let's say, higher level field sports, we probably want to make these change of direction drills more reactive. So reacting to, let's say, a ball, so running towards a ball, reacting towards another athlete, right? Reacting more towards pointing, kind of trying to recreate that game situation. And lastly, you have to layer in endurance with your change of direction drills. So basically having an athlete who not only changes direction well and can do it in a reactive manner, but also does this for multiple repetitions. And we should aim to have the amount of endurance the patient can tolerate be equal to what they're trying to get back to, right? So after the patient is tolerating some change of direction work for a few weeks, I start to pepper in some acceleration drills as well as some top end running, right? Now, depending on the patient and the pathology, you could make the argument that acceleration and top end speed stuff maybe comes before change of direction. I think that comes down to the person and the type of drills you're going to use. But this is what we did for this patient, right? So in terms of working on acceleration, I like to start with fall runs, right? Which may eventually turn into a half kneeling fall run just because it's a little bit more stress on the knee. We start with a lower RPE and we work to a higher RPE. So basically I tell people, let's have you start at a 6 out of 10 intensity, right? Or a 60% of what you feel like your max is. And we work that up over the course of time. We start with low and we progress to high volume. So I usually program, let's say 3 to 4 sets, work my way up to 6 to 8. We start with short distances and work to longer distances. So maybe initially we're only doing 10 meters and I work our way to, let's say, 20 meters. Be careful with more than 20 meters because at that point, you're not really accelerating anymore, right? You're more doing top end speed. And we also start working at top end speed at the same time. So I usually introduce top end speed running with my acceleration drills. And I like doing this through build up runs, right? Which is basically you pick a distance, let's say 40 meters to start, and you start running slowly and build up, build up, build up until you get to a top end speed, and you maintain that for a little bit and then break down, right? For these, you also start with lower volume, so 3 to 4 sets, and progress that to maybe 6 to 8 sets. You start with a lower intensity and work to a higher intensity. So that's how you can program it for your athletes. And then you start from a shorter distance to a longer distance. So maybe you start with 40 meters and you work your way up to 80 meters. And that's exactly what we did with our patient. He tolerated things extremely well, so he kept on working up over the course of time. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain-Free Mini Course. And we go over 3 lessons. Going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay, so a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a Fitness Pain-Free Mini Course. Definitely check this out.